I'm going to be speaking about a lady that I clocked a couple of weeks ago, a 37-year-old lady who had 2 weeks of worsening fatigue, generalized myalgia, and over the past week, she'd had reduced oral intake and reduced urine output and 8 episodes of vomiting. She then had presented overnight at 2 a.m. After waking with more acutely worsened bilateral flank pain and epigastric pain. And she was known to be day 5 COVID positive at this point. In terms of her kind of background and other history, so she'd also told me that she'd lost approximately 4 kilograms over the last 3 months. She'd had reduced appetite, particularly over the last week or so. She'd had increased itching, mild dysuria, and had been constipated. She denied any fever or night sweats or any other systemic symptoms. When she was 12, she was diagnosed with anorexia and bulimia. But since then, she hadn't kind of made herself sick or anything for over 2 years. This was unrelated to her eating disorder. She also reported that she had an MI at the age of 19, secondary to a severe anorexia bout where she'd been admitted, but that wasn't on her SCR. And she also has urge incontinence. So for those, she's taking omeprazole for some dyspepsia, solifenacin, and laxatives. No illicit drugs, no known drug allergies, no family history of note. And socially, she smokes 15 a day for the past 2 years and drinks minimally, approximately 10 units a week. Normally completely independent, working as an actress in radio and an eating disorder charity.
Okay, just hang on a second. So she had an MI, myocardial infarction, at the age of 19.
Yeah.
Okay.
Odd.
Odd. And did you hear anything more about that? Was it?
So there was nothing on her SCR. She just said that she'd had an MI while she was an inpatient for her anorexia.
Okay, and you say she lost 4 kilos. Are you going to tell us what her weight was?
So her weight was just over 50 kilograms and went just under, say, 48 kilograms.
Okay, any question on anybody else before we leave the history? And she's day 5 COVID, just in the first.
Day 5 COVID, yeah.
I was just going to say a report of an MI at the age of 19 would be unusual, but often anorexia patients can get cardiac arrhythmias and things where she may have had some sort of cardiac event. That wasn't necessarily what we'd medically describe as an MI, but a patient would call a heart attack if she'd had an arrhythmia or something or had to receive CPR.
Or like severe hypercalemia is often a problem in the patient.
Yeah. So yeah, often when people say they had a heart attack or an MI, they can mean other forms of arrhythmia or other sort of cardiac events, not necessarily a myocardial infarction.
Okay, so just moving on to the examination findings now. So from the end of the bed, she was alert, talking, but slightly tearful. A, B, C, and D of her A to E assessment were completely unremarkable and her observations were stable. When examining the abdomen, it was soft, but there was generalized tenderness in her epigastrium as well as on both flanks. And it was significantly tender when I was blotting the kidneys, worse on the right-hand side than the left. And there was no peritonism. So I'm just going to come out. So this is going to be the first question. So if we have a look at this ECG, I'm going to try and move to Kahoot at the ECG. But the answers are hypokalemia, hypocalcemia, hypomagnesemia, and hypercalcemia. Just go back to the ECG. So we've got hypokalemia is the only one that's answered. So the answer is actually hypercalcemia, which it's given away because I have to exit the slide. But if we have a look at the ECG, the first abnormality, so it's a in sinus rhythm, slightly slow at 59, so it's a sinus brady. If we look at the QTC, it's exceptionally shortened, so corrected to 277. And also, if you just have a look at the lead 2, I think shows it best, is this what's known as an Osborne wave or J wave, where you get this upward deflection between the QRS and the ST segment, and that's typical of hypercalciemia or hypothermia. So the first lot of bloods that came back, her HB is normal, white cells are slightly up, and the first significant abnormality that we come to is her creatinine. So she's got a severe AKI with a creatinine of 543 on a baseline of 80, and significantly uremic as well at 21. And then also for a 37-year-old female, her corrected calcium is 4.19, so extremely elevated. Otherwise, amylase is slightly up, but most of the bloods are completely normal at this point. Cool. So in summary, so far, we've got a 37-year-old lady who's presented with an acutely worsened bilateral flank pain, epigastric pain, on a background of 2 weeks of worsening fatigue, myalgia, and is day 5 COVID, who we now know to be hypercalcemic, severely hypercalcemic, and has a severe AKI. So with that in mind, I haven't actually got a question for this, but what would people's primary kind of differentials just based on the calcium alone of a severe hypercalcemia at this point be? Yeah, so malignancy. Excellent. And yes, hyperparathyroidism. Primarily, so 90% of hypercalcemia is caused by malignancy and primary hyperparathyroidism, 45 each respectively. And the remaining 10% come from endocrinopathies, medications like thiazides, and kind of thyroid problems, etc. So if we just move to the next question, sorry, I know, what's the commonest cause of hypercalcemia in hospital? Okay, yeah, so a bit of a mix, but malignancy coming out on top there, which is correct. So malignancy is the commonest in hospital, and primary hyperparathyroidism would be commonest in the community. And that's just generally because there's more people in hospital with malignancies, age, determinants, etc. So moving on now. So so far we've got our calcium, we've got our basic U&Es, but what further investigations would we want at this point if some people just want to whack some things in the chat? So PTH, vitamin D. First things you think about obviously are PTH. So in this lady, it's very suppressed. And if we move on to the next question, which is going to be, with such a suppressed PTH in this context, what would our kind of primary differentials be now? How would that have changed? So malignancy or other being the answers here. So someone with a calcium of so high over 4, you really need to be thinking about malignancy. Obviously she's a young lady, so maybe makes you think it could be some other source, but it's always got to be investigated at this stage. So in terms of malignancies, you're obviously thinking about solid tumors, things that are going to be secreting parathyroid hormone related peptides, so squamous cell carcinoma in the lung, other lung tumors, as well as kind of bony mets as well. And then obviously we want to think about myeloma, but we'll come on to that. At this stage, is there one investigation that we haven't had that would be helpful, normally done at the bedside when we get our initial blood tests that I've not given yet? Haven't given you any results with regards to a VBG. So if we look at the VBG that she's got, it's quite alkalotic with a raised PCO2 and an extremely elevated bicarbonate, so it's 45. So you can see that there's a kind of incomplete respiratory compensation of a metabolic alkalosis. So that suggests that there's obviously a metabolic component here that's leading to the diagnosis. So we'll come on to that in a moment. Just other endocrine investigations, so cortisol was completely normal, so we can forget about Addison's. TFTs were completely normal. Vitamin D was normal, so it's not going to be vitamin D excess. And we want to investigate for any suspicion of malignancy, as we said. So in her, she's got a raised calcium and a severe AKI. So 2 of the kind of crab symptoms when we think about myeloma. So we want to do a myeloma screen, getting electrophoresis and things, and that was all completely normal. And then we'd also want to get a chest X-ray, and that can give us information both with regards to potential malignancy, but also the things like sarcoid and TB, so the granulomatous diseases. Looking at this chest X-ray that she had, it's completely normal, it's completely clear, no obvious kind of masses or anything, no obvious sarcoid. Good. Fine. So what gave it away was obviously the gas being alkalotic with a raised bicarb, and actually something that I omitted earlier in the history was that when asked about over-the-counter medications, she had been taking 8 Rennies a day for over 20 years, every single day, which obviously quite excessive, and that's what's led to her diagnosis. If anyone can guess what her diagnosis is at this point, just whack it.
I think Dr. Danny wants to say it. I think she's been hinting about it for a long time now. Go on, Dr. Danny.
I think Dr. Thompson got the answer, didn't she?
Dr. Thompson, I apologise.
It was me. Can you hear me?
We can hear you.
All right. Okay. Yeah. All right. I kind of think I've rarely seen a calcium of over 4, or even you rarely see a calcium of over 3.5. The only other really weird thing I've seen is somebody that had primary often if you get two second diagnosis, it can sometimes be a problem. The most unusual case I've seen is somebody who had primary hyperparathyroidism and then was treated with calcipotriol for extensive psoriasis, which is a form of topical vitamin D. And I've seen that cause major problems, but this is a highly unusual level of calcium that I don't think you see very often, even in malignancy, even in myeloma. So kind of I suppose the title gave it away, really, didn't it? But yeah, I think you've got to look for always take a good history. The other sort of thing I've seen before is somebody who's had investigation after investigation for extensive diarrhea, but when somebody went and actually looked at what the patient was doing, they were chewing gum excessively, and gum contained sorbitol, so essentially they were giving themselves an osmotic diuretic, and it had been missed for years and years. That because nobody had actually sat down and worked out what people were actually taking in terms of their diet. So yeah.
But just to make it clear to everyone else that what we're talking about is milk alkali syndrome.
Yep.
Yeah. Thank you.
And
here they are. Here's the culprit. So just to kind of get to the salient results. So we've got this raised calcium, phosphate's completely normal with a suppressed PTH appropriately, a normal vitamin D, normal LFTs, and this, as we said, alkalotic VBG with a massively raised bicarb. So it gives us milk alkali syndrome with a classic triad that I'm sure everyone knew of hypercacaemia, metabolic alkalosis, and an AKI. The essential etiology is that overconsumption of calcium carbonate. It was first kind of discovered in the early 1900s when there was milk and an alkali, so calcium carbonate, milk and an alkali solution given for kind of dyspeptic symptoms. Then with the invention of PPIs and H2 antagonists, the incidence dropped. And then again in the 1990s, when people started giving calcium supplementation for osteoporosis, it again started to rise again. And essentially what you get is this alkalosis, which is due to overconsumption of the alkali. In addition to that, the high levels of calcium lead to hypovolemia and an impaired renal function. This alkalosis in turn will lead to further calcium reabsorption. So it almost feeds back in a positive feedback loop to increase the hypercalcemia further. And that is the combination that gives the overall triad. So I think just to say as well is that the Rennies, it says that you can take up to 12 per day, and obviously she was only taking 8. But I think because she'd had such chronic usage in the context of becoming acutely unwell with COVID, reduced oral intake, vomiting, so it kind of precipitated something that she was probably kind of running at a chronically elevated calcium, but not at the heights of what she came into hospital with. So just moving on to management quickly. So the kind of mainstay, so looking at her actual calcium level, she's in severe life-threatening hypercalcemia of over 3.5. And the mainstay of treatment in hospital is to really kind of rehydrate these people. So lots of IV fluids, kind of normal saline plus minus some potassium every 6 hours. In her case, obviously, the treatment was to counsel her to stop taking the antacids and to think about why it was that she was taking these. So if she was already on omeprazole, but we doubled the omeprazole. So if she was to have ongoing dyspepsia, then we'd need to consider something like an OGD or H. pylori management. But also, I think, interestingly, with her past medical history of having bulimia before and having spoken to her, I think there's a significant kind of psychological component to her taking these. So she kind of felt like she was doing something right and stopping herself from being sick by taking the Rennies. And she was fine with ceasing taking them.
And can I just ask, I always thought that maybe she was taking them as also, as you said, psychologically, as a food substitute in the background of her underlying mental health illness. And that's probably why she was taking more than she really, really needed.
Yeah, that's what I thought, yeah.
No, I agree. I think it's really right.
It's interesting. With other causes of hypercalcemia, obviously you want to treat the cause. So say if it was primary hyperparathyroidism, you'd want to take out the parathyroid gland that was causing the trouble. And also you can consider the following if it's kind of refractory. So thinking about oral bisphosphonates, denosumab, and cinacalcet in renal patients and things. But specifically for her and in the acute setting, you always kind of just want to rehydrate. And then just finally, we've just, in terms of the other investigations we went through in a young female that is presented with acute abdominal pain, obviously it's important to get a negative beta HCG to exclude any post-renal cause of her AKI and ultrasound KUB was performed. There was nothing on there, and there was also no stones as well that could have formed from these chronically elevated levels of calcium. CK was normal, so there wasn't any RAB there as well. And that's everything. So has anyone got any further questions?
Very interesting, and thank you. Any other questions about the severe? How is the patient now? Is the patient completely better?
Yes, I think she'd been seen by Kavita, one of the registrars in clinic a few days ago. Her calcium's kind of normalized now. She's not taking the Rennies, so seems to, and she's feeling loads better, funnily enough.
Yeah, and is she on omeprazole or something now? How is she coping with a peptic ulcer? Well, I'm
guessing...
Yes,
so she was on omeprazole, and I think she was also put on ranitidine as well, or one of the H2 antagonists. I think they were going to stop that and see how she gets on, but she's still taking omeprazole 40.